she she is still totally involved in the field. She works in a joined Costco and opened up a hearing center in Kansas City location. Megan was regional technical trainer supervisor in the Northwest or Northeast, Southeast, and in Texas regions in 2015. She returned to clinical practice in 2017 and is the senior hearing aid specialist at the Independence, Missouri warehouse, where she practices with training projects as needed. She is a perfect candidate to talk about in our testing who needs to be referred. I never get tired of this. And I never want to be held at the end on how I missed this individual. Okay, I never want to see that. And so that's why I like these kinds of things. And she's extremely bright on this. And so I welcome her. Megan, toward the middle of your presentation, if you would throw out a secret word that we can send back to let everybody know that we're here and enjoying your presentation. Other than that, if you need anything, just let us know. We're here to please.
All right, thank you so much. So today I am presenting on medical referrals and how they are more than just the FDA red flags. And I developed this course for an internal training, and that darn FDA just started making all sorts of changes in the past year. So some of this, I don't know where your state's at. Missouri has not changed anything that I have found yet, but we all obviously need to follow federal law and we have to follow state law. So if you're thinking, oh, that's not the way we do it here, just keep in mind every state can be a little bit different. So our learner objectives today are to identify asymmetric audiologic findings and determine appropriate recommendations. We're going to determine when word recognition scores are disproportionately low compared to the pure tone average. We'll be calculating and determining if there's a critical difference between word recognition scores, and calculate and determine the presence of rollover based on word recognition scores. So if you attended Dr. Steele's presentation yesterday, you're going to find that 3 of these, or at least 2 of these learner objectives, she discussed very much in detail. So I will be briefly going over them. I think it was a lot of information, and if that was new to you, I hope you'll find my covering it also helpful and beneficial, because I thought it was really interesting. She came at it from the perspective of this is what's going to be in the new IHS curriculum for the distance learning course. I came across the information that these are the best practices, when we are looking at asymmetries and we're looking at speech testing in particular, if we need to make medical referrals. And so the fact that everything matched what we're teaching our new licensees to know and what we are doing to determine medical referrals is the same information, I just feel even more confident that IHS made the right decision to include this stuff. And I feel very confident for you to include it in your practice when you're looking at medical referrals. All right, so in October, specifically October 17th, the FDA released a slight reworded warning statement for dispensers along with their FDA red flags. And this came about with the recent approval of the over-the-counter hearing aids, and the details are in the Federal Register document. Many states, though, incorporated the original 1977 FDA red flags into their own regulations. So like I was saying, Missouri, we're still on the old 1977. They've not updated yet. So be on the lookout for your state as they may be making changes. I have highlighted the changes in the wording for you. And I've also provided the original wording for your reference. So as licensed providers, we are still to advise prospective hearing aid users to promptly consult with a physician, preferably an ear, nose, and throat specialist, before dispensing a hearing aid if through the case history, physical examination or review of other information, such as their audiogram, that the prospective hearing aid user has had any of the following conditions. And those conditions include visible deformity of the ear, either congenital or traumatic, fluid, pus, or blood coming out of the ear within the previous 6 months. So some of these revised statements are a little bit more detailed, and they also have included a longer duration of 6 months versus 90 days. So pain or discomfort in the ear, history of excessive wax or suspicion that something is in the ear canal, dizziness, either recent or long-standing, sudden, quickly worsening or fluctuating hearing loss within the previous 6 months, hearing loss or ringing, and they say tinnitus, only in one ear, or a noticeable difference in hearing between ears. So that is definitely a new statement that we have not had to that specific wording before. And then audiometric air-bone gap equal to or greater than 15 decibels at 500, 1000, and 2000 hertz. And I always like to remind people that, you know, saying yes to any of these conditions doesn't mean I can't test them. It just means I shouldn't dispense a hearing aid before they've been medically evaluated. Your thorough and complete audiogram with an appropriate medical referral not only provides the best care for your patient, but it also is the best marketing for you can do for yourself as a hearing healthcare professional and to promote our profession. I have seen, you know, working in ENT where people get air-bone gaps and they just stop the test all of a sudden they don't finish. There's nothing better than sending a full and complete audiogram to that ENT. They will send the person back to you, partly because they want the referral, they want your medical referrals. So they're not just going to keep them, but you do have to do complete work. You need to do excellent work. You need to mask, and they're more than happy to send them back to you. In most situations, there's always the one person that doesn't do that. So when we're in an appointment with a patient, you'll have the opportunity to glean information from 3 sources, and each of these sources may result in a referral: what they report to you in their case history, the otoscopic examination, and your audiometric evaluation. So I first want to separate out the FDA red flags into these 3 sections, but then I'll also be including referral criteria that the American Academy of Otolaryngology Head and Neck Surgery, which I'm just going to call them AAO to keep it a little simpler. So we'll be looking at what they recommend, as they do represent our ear, nose, and throat physicians and medical specialty. And although the updated FDA red flags are an improvement, in my opinion, I still think they can miss a lot of medically necessary referrals. But I also think it's important to say that if we just go by the AAO guidelines alone, we could potentially lead to a lot of over referrals. So there has to be some balance. But more importantly, I hope that today you learn and apply some objective measures to confidently determine when a medical referral is necessary. So let's first look at reasons why we might refer a patient based on their case history. So fluid, pus, or blood coming out of the ear within the previous 6 months. Now this one can be a bit tricky, as they may not have any current signs of this during otoscopy, especially with that extended duration of 6 months versus 90 days. So sometimes when the patient client describes to us, it doesn't even make sense what they said was coming out of their ear. But the new FDA guideline is more in line with the AAO recommendation. And if the patient client reports a history of it, but none is visible, you are definitely fine to test, but then we want to refer them before proceeding with dispensing amplification. Sudden, quickly worsening, fluctuating, sudden onset, or rapidly progressing hearing loss are all reasons to refer also. The FDA now specifically specifies within the last 6 months, but notice the AAO does not put a time frame when they say sudden onset or rapid progressive hearing loss. So without trauma, hearing loss should not just happen suddenly, and it should not fluctuate if it is normal sensory neural hearing loss. Hearing loss only in one ear, or a noticeable difference in hearing between ears, or unilateral or asymmetric hearing loss. We're going to spend quite a bit of time later talking about unilateral hearing loss and what quantifies an asymmetry. Dizziness, either recent or long-standing. It's important to know if they've been seen by a physician regarding their dizziness. Do they have a Meniere's diagnosis? Have they been treated for benign paroxysmal positional vertigo or BPPV, where they'll say the rocks in my head are loose, or you can tell them the rocks in the head are loose. I also want to question if dizziness is where they feel like they're spinning. Is the room spinning, or is it just more of a lightheaded feeling? Many patients will say they get lightheaded when they stand, and this can indicate orthostatic hypotension or a form of low blood pressure that they should see their primary care physician about. However, it also could be an otologic, neurologic, or another medical condition causing that symptom of lightheadedness. So this is where our complete audiogram can be helpful to the medical provider they see for that further evaluation. Pain or discomfort in the ear. If this is occurring today, we might not even be able to do the test. That pain could be from an ear issue, or it could even be possibly due to a dental or jaw issue. Unilateral tinnitus is now a recommendation from the FDA along with the AAO, and it's another example where that complete audiogram could be very helpful in their diagnosis. The AAO also includes pulsatile tinnitus in their red flags, and this could be reported to you as like a rhythmic thumping or a whooshing in the ear, and it could be caused by a disorder or malformation of blood vessels, which could lead to an aneurysm. So it's not just traditional tinnitus that they're talking about. There's something else going on that we want to refer for. And then obviously individuals under 18 years of age, your state will have specific requirements for fitting these individuals. Usually that requirements that they've seen an ENT and an audiologist within the past 6 months. And then there are some other reasons to refer. So the AAO also recommends a referral with any report of hearing loss, and then also a positive history of ear infections, noise exposure, familial hearing loss, tuberculosis, syphilis, HIV, Meniere's, autoimmune disorder, ototoxic medication use, otosclerosis, von Recklinghausen's neurofibromatosis, Paget's disease of the bone, and ear or head trauma related onset. So as I said, sometimes the AAO, they're going to be seeing every single person that has hearing loss because they do have quite an extensive list. So that's where we want to make an informed decision on that medical referral. All right. So otoscopy-based referrals. So once we've obtained that thorough case history and we follow infection control protocols, we'll form otoscopy. So for an adult patient client that has a congenital or traumatic deformity of the ear, they're most likely going to have already been medically evaluated. However, we do still want to ask that they've seen a physician regarding this once we observe it. Dry ear precautions should be recommended if you see a hole in the eardrum that's not been previously diagnosed. Some of our patient clients may even have a PE tube. These should be patent or open, but it's not always possible to view depending on the angle in the tympanic membrane. And this is where tympanometry could be helpful. It would show you that you have an abnormally large ear canal volume to let you know that tube is patent. When otoscopy reveals significant cerumen accumulation or if a foreign body is found in the ear canal, they should be referred prior to testing. And then the AAO and now the FDA further specify to refer when blood, pus, cerumen plug, foreign body, or other material is found in the ear canal. And if there is currently fluid, pus, or blood in the ear, I would refer without testing first. We also need to consider referrals based on abnormal tympanic membrane appearance. And an easy way to remember this is red, white, and blue. So normally these are very patriotic colors for us, but if you're seeing any sort of patriotism in the ear canal at the eardrum, be concerned. A dark red appearance could be a suspected hemotympanum or blood behind the eardrum. A white mass could potentially be a cholesteatoma with a retraction pocket. And a tympanic membrane with a bluish hue could indicate Glom's tympanum or a tumor behind the eardrum. And the most common symptom for that is that pulsatile tinnitus that I mentioned earlier. And they may also have other symptoms of a conductive hearing loss. Due to that obstruction, they may also have ear pain and bleeding. So red, white, and blue eardrums are not a good thing. So now let's just take an overview of audiometric evaluation-based referrals before we dig a bit deeper into some of them. So audiometric-based referrals include an audiometric airborne gap of 15 decibels or more at 500, 1000, and 2000 hertz. Make sure you know specifically what your state regulation has regarding airborne gaps. That's one thing I learned having about 150 stores as my responsibility, is that different states have different requirements for airborne gap consideration. Unexplained conductive hearing loss or abnormal tympanogram. If a patient reports a history of otosclerosis and they elected not to have surgery, or that surgery wasn't successful, then I'm not going to be surprised there's a conductive component to their loss. That's not unexplained. They've already told me that history. Abnormal tympanograms would potentially include an A sub D, a type B, or potentially a type C tympanogram. Unilateral hearing loss, with the air conduction PTA of 5, 1, 2, and 3. So they're saying a unilateral hearing loss with a difference of 15 dB or greater is what the AAO recommends. And then a bilateral hearing loss greater than 30 decibels. So this is definitely an example where the AAO referral criteria would lead to over referrals, as this is essentially everyone we're seeing in our clinics. You know, a 30 dB loss is not unexpected or greater. Unilateral or asymmetrically poor speech discrimination scores. And the AAO defines this as a difference between ears of 15%. Dr. Steele talked about the Thornton and Raffin chart, which we're going to look at again today, so that we can really determine if a difference is a difference. They're also suggesting a bilateral speech discrimination score of less than 80% is cause for referral. So once again, an area of possible over referrals that we'll discuss in more detail. So let's take just a minute and look at what the FDA criteria for an airborne gap looks like. We'll take a look at some audiogram examples. So this first audiogram on the left would require a medical referral, as we have airborne gaps at 5, 1, and 2. I think we all easily agree with that. However, if we solely look at the FDA criteria, this audiogram on the right would not meet that criteria because of that little word "and." There's an airborne gap at 5, 1, and 4, but not 5, 1, and 2. So the FDA criteria misses the typical pattern of otosclerosis due to the Carhart notch depression that we typically see at 2000 hertz. This is a classic textbook example of an audiogram describing otosclerosis. Be very typical of the one on the right here. But this also assumes a younger patient client, or at least someone without any sensory neural hearing loss. Otosclerosis, though, can develop later on in life and often goes unevaluated, since many think hearing loss in one ear is a normal occurrence. I find that interesting. People go, I can't hear on my right ear, and it's been that way for 15 years, and they've never been tested. I'm like, that's not normal. Your ears go everywhere together. They're best friends. They should be the same. All right. Now let's take a look at how otosclerosis may present in the actual hearing aid clinic. So we'll take a moment to look at 2 more audiograms, as this is what we would typically see. In this first audiogram on the left, we have a mild to severe sensory neural hearing loss for the right ear and a mild to severe mixed hearing loss for the left. On the right here, we have essentially the same audiogram, except the only difference is 5 decibels at 2000 hertz. The audiogram on the left bone mass threshold at 2000 is 50, and the audiogram on the right has a threshold of 55 decibels at 2000 hertz. So if we take the FDA criteria literally, it would say to refer the audiogram on the left, but not the audiogram on the right. And the problem is this could be the exact same patient, and we're just seeing a 5 dB difference in bone conduction threshold that's within our retest reliability. In this scenario, the audiogram on the left indicates some sort of middle ear pathology, whereas the audiogram on the right also indicates a middle ear pathology and leans more towards a diagnosis of otosclerosis, as we now have that Carhart's notch. If the diagnosis was otosclerosis, and a stapedectomy is not going to restore their hearing to normal, as there's a sensory loss still observed. But this patient client should still be evaluated medically by an ENT, just like the patient on the left. If surgery was feasible for this person, they could potentially have better sound localization, greater awareness of sounds when amplification is not being worn. They could have a more open hearing aid fitting and improved power consumption with their hearing aid. Plus, we aren't able to make the diagnosis of otosclerosis. We can just observe typical patterns on audiograms. This could potentially be a more medically dangerous condition that may have remained undiscovered without that medical referral. All right, so let's talk about unilateral hearing loss. One of my favorite topics. And what exactly quantifies or qualifies unilateral hearing loss. And it can be a bit vague, as the FDA red flag is to refer if there's hearing loss in one ear or a noticeable difference in hearing between ears, but that doesn't exactly quantify a unilateral loss. The AAO does specify a quantity of unilateral loss as an air conduction PTA at 5, 1, 2, and 3. And so I call this a modified PTA when we add in 3000 hertz. And if there's a difference there of 15 decibels or greater, then the better ear. And just to review, the most frequent causes of unilateral sensorineural hearing loss are sudden deafness, often caused by a virus, Meniere's disease, a cerebellopontine angle tumor, and additional causes of unilateral hearing loss may include genetic or hereditary factors, syndromes, illnesses, head trauma, traumatic brain injury, viral or bacterial infections, and noise exposure. All right. So sudden sensorineural hearing loss, we're going to look at some referral considerations. This is hearing loss that occurs within 72 hours or 3 days or less. It usually occurs in one ear, but it can occur in both, although that is very rare. In the United States, sudden sensorineural hearing loss happens to about 66,000 individuals a year. 90% of those cases are idiopathic or they do not have a clear cause. Although hearing loss is the main symptom, individuals may also have tinnitus, pressure, and or vertigo. Sudden sensorineural hearing loss warrants immediate medical referral, as only about half the patients will get their hearing back on their own. Oral steroids, intratympanic steroid injections are the usual course of treatment. Patients with a mild to moderate severe hearing loss have a better chance of recovery than those that have a severe to profound loss. So when a patient calls and, I need a hearing test, I can't hear out of one of my ears, we need to make sure we're probing further. We have our desk staff, ask, when did this happen? Anything that's happened, within the last couple of days, we want them to see an ENT. And most ENT offices, their staff are trained. If someone says it's a sudden loss, to get them in quickly, they'll work them in lunch, they'll stay late. I always get concerned when patients go to their primary care physician, as I've seen a lot of these treated as an ear infection and they were given an antibiotic. And 6 weeks later, when they still can't hear, then their PCP refers them to ENT. So I do think it's wise to refer these patients on. Now, absolutely, could an ear occlude with wax overnight? That little pinhole that they had in the wax can close up and they're going to have that same symptom. So if you have the opportunity to check their ears, that's great. If you have time to get them in for a test, that's even better. But we just don't want to put these individuals off. And so if you're not able to see them immediately, I would go ahead and encourage them to see the ENT. I'm going to take just a couple minutes to discuss acoustic neuromas. In my mind, these are always the worst case scenario. And from a case history perspective, possible indications of an acoustic neuroma include unexplained unilateral or asymmetric hearing loss, persistent unilateral asymmetric tinnitus, vertigo, dizziness, aural fullness, facial paralysis, or paresis. And so, 4 of these symptoms are the same thing for someone that had a sudden sensorineural hearing loss, and it's most likely a virus. So these symptoms are very common, and the diagnosis, can definitely vary. So we want a medical professional to evaluate these. The National Institute on Deafness and Other Communication Disorders explains an acoustic neuroma may also be called a vestibular schwannoma. The type of tumor is benign and usually slow growing that develops from the 8th nerve. It can become life-threatening if it continues to grow and presses on the brainstem or the cerebellum. And because of the benign and slow growing nature of these tumors, most are just usually monitored, and as there are a lot of risks to removing them, but a timely and appropriate medical referral must be made. So the AAO has suggested that pure tone thresholds suggest potentially suspicious results when there's a 15 dB or greater average difference in air conduction thresholds between ears at 5, 1, 2, and 3, so that modified PTA. Let's take a look at an audiogram example. When we look at this audiogram on the left, and I'm backwards all day long and left and right, so to say that this is my left and it's not the right ear is driving me a little bit batty, but I'll get my sides correct here. So when we look at this audiogram on the left, we can easily see there's a difference between the right and left thresholds. The software provided PTA also reflects that there's a difference of 19 decibels. However, we need to keep in mind that the software in our systems is usually not showing us a modified PTA that the AAO referral recommendation is based on. And this is important when we look at this other audiogram on the right. Because on this one, when we actually modify that PTA ourselves, we'll find that we do have that difference. So when we include 3000 hertz in our modified calculation, this person actually does have a 15 decibel difference between PTAs, as the modified PTA for the right ear is actually 40 and not 35, and the modified PTA for the left would become 55 when we include 3000 hertz and not 48. So we would have a 15 decibel difference. So just make sure if you are looking at referring on 15 dB difference, you are calculating your own modified PTAs. As mentioned before, many of the AAO referral guidelines may create over referrals and potentially increase patient anxiety. Please note, we're never going to say to someone, I think you have a tumor. That is way beyond our scope of practice. But there are definitely findings that we know are not normal. And as I said earlier, I always tell patients, you know, your ears go everywhere together. If one ear is different, we have to look to see if there's something medically causing this. And that's what the doctor is there to evaluate you for. That's beyond my scope. So let's take a look at a set of pure tone considerations that are a bit more specific than what the AAO has recommended in the past. So the additional criteria looks at specific frequencies. And so Obholzer and colleagues reviewed audiograms and reported symptoms of all patients who had MRIs obtained of the internal auditory meatus back in 2000, and they found a specific criteria that had greater than 95% sensitivity. So that's the ability of a test to correctly identify patients with a disease. And it had the highest specificity, the ability of a test to correctly identify people without the disease of 49% by utilizing an intraoral or between ear difference criteria at 2 adjacent frequencies. That difference being 15 decibels when there is a unilateral hearing loss, and an intraoral difference of 20 decibels at 2 adjacent frequencies for those that have a bilateral hearing loss. And so I actually like this criteria better than just using a modified PTA. It takes into consideration frequencies 3000 hertz and above, which the AAO criteria does not, and it differentiates a more conservative criteria when there's an individual with a unilateral hearing loss and they just have hearing loss in one ear versus the person that has a bilateral hearing loss. So here are 2 audiogram examples that reflect this criteria. The audiogram on the left reflects a unilateral hearing loss with a 15 decibel difference at 2 adjacent frequencies. And actually there's that difference at 4, but it had at least 2. And the audiogram on the right reflects a 20 decibel difference at 2 adjacent frequencies at 3 and 4000 hertz with a bilateral hearing loss. I think it's important to note that the authors refer to 2 adjacent frequencies and they do not say octaves in their criteria. Both of these audiograms indicate medical referral for asymmetric pure tone thresholds. There are several aspects to word recognition testing, and we're going to get into this further. And this was a lot of what Dr. Steele talked about yesterday, that will help us determine further in our appointment. So some more diagnostic audiology appointments, we're going to do rollover. They're going to look to see if the word recognition score decreases significantly at that louder intensity. The AAO includes a difference of word recognition scores of 15% or greater as a difference, and could be a possible indicator of a vestibular schwannoma. And we're going to talk further about the Thornton and Raffin statistical approach to determining those differences. So we all know that word recognition has a lot of variability, and therefore we must ensure we're testing word recognition correctly before we start comparing those scores to one another. Word recognition is an easy test to score. Is the word right or wrong? But we always have to question, am I scoring words wrong because I'm not conducting the test appropriately? We have to consider that each and every time we do the test. And so these are two articles on Audiology Online that I think are great reads. I think she recommended, Dr. Steele yesterday recommended the first one. Dr. Mueller's an author on both of them, which is why I hesitated on that. The 20 question one though, it's one of those 20 questions and they actually ask more than 20. So I do believe that is a 3-hour CEU. If you are looking to get more hours, that is a great one. But both the articles are great. They do talk a lot about the same thing. So I'd like to talk about word recognition testing in general before we talk about possible indications of vestibular schwannomas. I want to take just a minute to talk about word recognition testing is not. It is not a test to determine how patients are going to perform in the real world. After all, we're testing them monoorally with monosyllabic words, ideally with insert earphones in a quiet test booth, and they have no visual cues. The purpose of word recognition testing is to determine their optimum performance, or that PB max. And I do remember the candy bar, and it was excellent. If you've not had a PB max, I'm very sad for you. So we're looking to see, how does that word recognition score, how good does it get, and what is the best we can expect from this person? We have to keep in mind that we're trying to determine that optimum performance obtained in such a standardized way that we can confidently enter our findings into the patient client's medical record. So testing one word recognition list per ear doesn't mean that I've necessarily obtained their PB max. But as we kind of discussed yesterday, I mean, who really has enough time or even enough word list to test at multiple levels? And so this is why it's critical that we test at the most appropriate level the first time, and then evaluate if the score obtained is in agreement with their hearing loss. Valid and reliable word recognition scores can be used to determine if their performance agrees with their pure tone hearing loss. It can identify an unusual asymmetry that is not predicted by the hearing loss. I'm sure we've all had a very symmetric pure tone results, and then all of a sudden you do word recognition and one ear gets an 88% and the other ear gets a 42. Well, I wasn't expecting that. And often that'll be the ear they say they're using on the phone, which always surprises me. Word recognition scores can be used to monitor their performance over time through sequential testing, and they can assist in helping us make monaural versus binaural amplification decisions. All right, so there are many different methods that have been used to obtain the word recognition score, and I'm not going to go over all these various methods. But we are going to focus on the method that IHS has now put in their curriculum that was discussed yesterday, and that's that sensation level based approach. And that the presentation level is based off their 2000 Hertz air conduction threshold. And that's what's going to help us determine the intensity for word recognition testing. So to test using this method, you will use the 2000 Hertz air conduction threshold for the test ear, and then you're going to add the appropriate sensation level to the threshold. So as their threshold declines, or we're having to go at a greater intensity, you're going to add a little bit less and less sensation level, because we know that there's going to potentially be recruitment. And so yesterday I did listen to her presentation, and she talked about, how we have our little sticky notes everywhere. I'm more of a label maker person, so this is actually we use the Oracle system. So this is at the base of my computer monitor so that I have those numbers there so that I can see exactly how much sensation level I need to add to each of intensity at 2000 hertz. All right. So let's take a look at an example. Let's first look at this left ear. The 2000 hertz threshold is 45 decibels. For thresholds 45 dB or less, we want to add an additional 25 dB. So for the left ear, we would actually be presenting at 70 dB HL based on the 2000 hertz sensation level method. For the right ear, the threshold at 2000 is 55. So we would want to add an additional 20 dB. So we'll be presenting at 75 dB HL. And these levels seem really appropriate for their loss. It's not exceeding the UCLs, and I wouldn't necessarily have their UCLs before I did word recognition testing. And so, as mentioned yesterday, if you are mentoring apprentices, you're training individuals, it is important that you be very familiar with this method, as this is what they're going to be seeing on their upcoming exams. All right. Oh, sorry, I forgot I had those in there. All right, we can advance now. So how do we determine if word recognition scores are normal for the hearing loss we're seeing on the audiogram? Is the word recognition score what we would expect for loss? And obviously with experience, I'm pretty good at guessing that, but guessing it isn't good enough. We learned yesterday that there is actual data to help us know if the word recognition score is appropriate for the degree of loss based on the PTA. So Dubno and colleagues obtained word recognition scores at several speech levels for 407 ears, and they were able to calculate to a 95% confidence interval, meaning only 5% of scores fall outside of this range if a score was disproportionately poor in relation to the degree of hearing loss. So let's take a look at an audiogram example, and then we'll use the Dubno data to determine if that score is appropriate. So let's orient ourselves to the chart. So first of all, the Dubno data and the Thornton and Raffin, those are two independent studies. They have their own charts. And then the sprint chart is a combination. And so I have broken it down by chart first, and then I may show you sprints depending on the amount of time when we get there. So the column on the left of the Dubno data shows the pure tone average, and the column on the right has the cutoff scores for word recognition. We can take our pure tone average for the right ear here, which says 25 dB, and see that our cutoff score is 80%. So we have a PTA of 25, our cutoff score is 80%. They actually scored an 84%, which is above 80. So this word recognition score is appropriate for their degree of loss. If we take a look at the left ear, the PTA is 33 and the cutoff score is 70, which is their exact score. So this is also appropriate. If it was disproportionately low, we may want to do another word recognition test at a higher intensity, or maybe our intensity is high and we actually need to lower it. Potentially, do we have some sort of rollover effect? If we still found that that PB max for them was below the degree of loss, we may find that a medical referral is necessary. All right, so through grad school, for some reason, the Thornton and Raffin 1978 is the only study that I still remember in my head, because I Google that table a lot if I don't have it right with me in a booth. So this goes back to two of the possible indications of vestibular schwannomas. So we can use a statistical approach for asymmetric word recognition scores that's more specific than just 15%. 15% is obviously a difference, but I really like using this data to know without a doubt. So these findings were published in 1978, and this study has been replicated more recently in 2007 and only found minor differences. So we are still using the Thornton and Raffin data. So this table can be used to compare 2 word recognition scores either between test session or between right and left ears. Orienting ourselves to this table, we have our score percent on the left side. Then we have our 50 word list as the middle column. We have our 25 word list as the second column. Yesterday, we talked about the importance of 50 word list. And I would say if we're going to refer someone for their speech scores, we definitely need to give them the benefit of the doubt and give them a 50 word list. So I know there's data for the 25, but give those 50 words. And if you use the expedited protocol, if you're using the 10 most difficult word list, if they score less than an 88%, it requires that you do all 50 words. And I'm not really concerned with someone that's got 88% speech understanding. It's probably not why I'm going to be referring them. So anything worse on the expedited, if they miss more than 3 words in the first 25, that does require you to do all 50. So once we look at someone's audiogram, I always say pick either the better score is the score percent or the worst score. It doesn't matter, but just be consistent. So we'll use the word recognition score of the poor ear for the test session to find our place in the score percent column. And then you're just going to slide over to see what that range is. Okay. So this first score is 80% and the second score is 56%. So I like to start with the poor score and we can see what that range is. I can't see it because of, I see people, which is fun. Oh, it says 38 to 74. So we are not within range because our better score is 80%. So that exceeds the 74. So this would be a significant difference, whether this was between ear to ear or between last year's word rec and today's word recognition. Okay. So this is where the magic happens. So we've got the Thornton and Raffin, we've got the Dubno data. They're both 2 great resources. I do have a handout that I'm going to post the link to in the comments before we're done. So you have that. It's on Google Drive. I think you'll be able to access it. Because in the moment of testing, as much as I love Sprint, that all the data is one, I kind of need like my fingers to run across. And sometimes I'm still testing when I'm looking at that. So these charts might be easier to look at, but Sprint is readily available. This information is also available on the internet. So I broke Sprint down, and yes, I am the person that actually created my own Sprint chart because the print quality that I was finding in articles was just a little bit blurry. So instead of using arrows, I just used color for the Thornton and Raffin data, which is across the middle of the chart. And then the Dubno information is shaded on the left side of the chart. And during yesterday's presentation, she was talking about the scores. I was like, ooh, when the scores are shady and we don't really think they're appropriate with the loss, they're on that left side. So if that helps you a way to remember that shaded scores, if you're meeting points in the shaded area, those are shady, and we need to look at that data a little bit more closely. I am going to skip through this just for time's sake, and I know you all did it yesterday, but this would be looking to see if the score is disproportionately low. And then this is looking to see if there's a difference using the Thornton and Raffin data. And then there it is all together. If you like this, I can make it into a PDF and include that. My email is at the end here. Like I said, Sprint chart is readily available on the internet. I just didn't really like the print quality. All right, let me advance here through my notes. Okay. So the third consideration for word recognition is to evaluate for rollover. So patient clients with eighth nerve or low brainstem lesions almost always do poorly in word recognition tests, but they're going to do even worse when their neurons are stressed at a higher intensity presentation level. When a person does significantly worse at higher intensities, that score is said to have rolled over. And you may see this on audiograms from audiologists where they'll test word recognition at 40 dB SL and then they'll do 80 dB SL. And that's kind of their, I'm going to check for rollover. And a lot of times they'll do it pretty standardly in the ENT environment. So I'm going to take just a moment. I'm going to grab a sip of water, and you all can write down the key word, which is referral. Very creative, I know, but the key word is referral. And just to remind you, I'll remind you, no referral is a bad referral, okay? If you just have this gut feeling like something just doesn't seem right, go with your gut instinct, okay? But we do have data that we can go by too, but so I'm just going to briefly talk about rollover because it is very old. And with today's MRIs, I mean, a physician puts someone in an MRI without even questioning too much stuff at this point. I like to run rollover because I will do it when, you know, someone has poor word recognition. I'm like, well, let's go up a bit and see how they do. And then they drop. I'm like, oh my gosh. So determining rollover is just taking their best score minus their worst score, dividing it by their best score. Depending on the word list does change what that rollover index is. So for those using NWHAS 6, Meyer and 85 found a rollover index if it's greater or equal to 0.35. The Jerger data, I think that was from 71 or I think 71. It used PAL PB50 words, and so it was 0.45. But obviously we need to use data for the lists we're using. So here's just an example. On their right ear, they scored a 76%. Then we raised it to 85. We have appropriate masking. They got a 36. So we're going to take 76 minus 36 is 40. Divide that by their best score of 76. And we find that that right ear is positive for rollover. It's greater than 0.35. We can do one more real quick because it's pretty quick to do. So this time for their left ear, they have a score of 64%. That's their best score minus their worst score of 50. So we get 14. We divide that by their best score of 64. We get 0.21. So that is negative for rollover. So I don't look at it as going, oh, this is a tumor. I don't look at that. I just look at it to see just one more thing to have in my basket to help support my reason for referring someone or for not referring someone even. I will use it for that purpose too. Okay, so this is just the big picture of possible indicators for vestibular schwannomas. Additional testing may include, like I said, the rollover, acoustic reflex thresholds, acoustic reflex decay, ABRs. But in today's medical world, I mean, people are sent for MRIs all the time. There are some individuals that can't have them. And so maybe additional testing would help support the doctor to really push for why they need to do an MRI, although it may not be their preferred test. Sorry, I went back. Okay. Just a couple of more things. So the British Academy of Audiology included a few more reasons to refer that were not covered by the FDA and AAO. So I think it's nice to know what, you know, other people in the world are referring for. So altered sensation or numbness in the face or observed facial droop. Urgent medical advice should be sought if these symptoms have not been previously investigated. Hyperacusis or an intolerance to everyday sounds that causes significant distress and impairment in social, occupational, recreation, and other day-to-day activities. Normal peripheral hearing, but with an altered auditory perception or abnormal difficulty hearing in background, noisy backgrounds. This could include problems with sound localization, perception of pitch, loudness, difficulty following complex auditory directions. And then adults with sensory neural hearing loss, which does not appear to be age-related. Where appropriate, they need to be referred for possible etiological investigation. Okay, so I want to just talk real briefly about cochlear implant candidacy, and that was part of my prior life. When I worked ear, nose, and throat, I was a cochlear implant audiologist as part of my time there. So I just want to quickly go over some standard guidelines for when to refer the patient client for candidacy. But let's talk about first a little bit what happens at that appointment. So the initial evaluation for cochlear implant candidacy takes place with an implant audiologist and most often an otologist. They're going to obtain a thorough case history for hearing and medical. The otologist may order some imaging studies to see if it's even possible structurally to put an implant in. And the implant audiologist will be conducting standard diagnostic hearing evaluation, and they're also going to be obtaining aided testing. And the actual candidacy criteria from an implant comes from the aided test and not the unaided hearing ability. Although it is part of it, it is really what they can do with those hearing aids that's most critical. So it's critical if you know you have a patient going for evaluation that their hearing aids be set to rim targets, because if the hearing aids are not set to targets, they're going to send them back to you, or they're going to have to adjust them. They're going to probably need 30 days at those settings before they would consider those test results valid. The Center for Medicare and Medicaid Services, or CMS, determines the following in their decision summary: that cochlear implantation is reasonable and necessary for treatment of bilateral sensory neural moderate to profound hearing loss in individuals who demonstrate limited benefit from amplification. And limited benefit is defined by test scores of less than or equal to 40% correct in the best aided condition on recorded test of open set sentence recognition. So they are being tested with sentences with their hearing aids set best for them. So I believe this came from Cochlears Americas, but what they have found is if we will look at our PTAs and word recognition scores, that can really give us good criteria for when we need to refer. So since open set sentences is not one standardly done during a hearing test, the manufacturers of cochlear implants reviewed their data, and they found that 95% of CI patients have a PTA of 60 dB or greater in their better ear. And regarding word recognition scores, they found that those who meet traditional candidacy criteria, 92.3% of those patients had an unaided word recognition score in the better ear of less than 60%. So they're kind of teaching the 60-60 rule. So using the PTA of 60 dB or greater and a word recognition score of 60% or worse in the better ear resulted in a correctly identifying 82% of CI candidates. And the 18% that were misidentified as possible candidates left that appointment more informed and knowledgeable about cochlear implants. And so there's been a push, like I said, at least from Cochlear Americas, for the 60-60 rule. And, you know, they say no referral is a bad referral. So if you have people that are struggling with word recognition, you have them set to the best of those hearing aids capabilities, the best capability of any hearing aid that you have available, definitely consider an implant evaluation. I would rather send someone sooner rather than later. I want them to start those relationships. I want them to get that information before they have an even greater difficult time understanding the information that's being presented. Okay, so in my state, we are required to do medical waivers still at this point. So a person can sign a medical waiver when a hearing loss is symmetrical, it's sensory neural in nature with unremarkable history, unremarkable otoscopy. When the word recognition scores are in agreement with the degree of hearing loss, and we know that from the DEBNO data, and with the word recognition scores are in agreement between ears with symmetrical sensory neural hearing loss. And we know that from the Thornton and Raffin data. We do want to make sure that if we're not comfortable with them signing that clearance, if there's abnormal results, that we do make a medical referral, that we suggest that they see an ear, nose, and throat physician. Otologists are ENT physicians, but otologists further specialize in the ear. And usually when I have something unusual, I recommend they see an otologist, but sometimes those are not available in your area. Then there's the medical referral process. We use a form that has the medical clearance on it. So we've got referral at the top, clearance on the bottom. I make a note because it's easy as documents get scanned in. We have electronic records to keep track of people. We use Cycle. And so I actually set a to-do to remind myself to communicate with this person in 30 days, just to check and see, did you see the doctor? You know, what they say, what are the next steps? This is in no way a sales call, but this is just, I'm concerned about you. I'm curious also what was going on. And then they would come back with that signed medical clearance if they wanted to pursue amplification. And obviously you want to make sure you have all that documentation scanned and or in their records, however you do it at your office. So if we have their medical clearance, do you need to retest? And so it never hurts to retest someone. And that way we're always fitting based on their most recent hearing status. We'll definitely need to test or retest them if any treatment was done. You know, was the wax removed? Did they have a myringotomy? Was fluid drained out from behind the eardrum? Did they have steroid injections? Did they take a steroid? Was there surgery done? You know, all those are things we hope improve the hearing. We hope those resolved ear bone gaps. But sometimes they're not able to do surgery. Sometimes they choose not to do that. If a patient just had imaging studies done, they probably don't need a retest, but given, I don't know what amount of time has passed, you may still want to go ahead and do that. So this is just a quick overview of kind of the whole referral process, because I did present a lot of information. Hopefully some of it was new, some of it was refresher, and some of it you might have been bored through, I don't know. But this is just kind of a brief summary. So we'll start with the hearing test appointment. If the patient client's history is remarkable, we can test if we're able to, and then we would refer to ENT for whatever that remarkable result was. I like to set a reminder to follow up with them if I've not heard back from them in 30 days. And then if they've been evaluated and have medical clearance, then we can proceed with fitting them and retesting as needed. When the history was unremarkable or normal, we'll move on to testing the patient. And if the test does not reveal a symmetrical sensorineural hearing loss with word recognition in agreement with the loss and an agreement between the ears, we'll refer to the ENT for a remarkable test result and do that same 30-day follow-up process. And if the hearing test is symmetrical, it's sensorineural, our word recognition is in agreement with the loss, we have agreement between the ears, then I would proceed with having them sign the waiver if it's required in your state and fit appropriately. All right, so I have the link here and I will add it to the chat in just a second. I have it ready to go. So you should have that link. I haven't shared anything like that from Google before, so if you need to email me, that's fine. But what I've done on this quick reference, it's something you can laminate, put in a little page protector. I've got the Thornton and Raffin data. I've got the Dubno, and I also have the 2000 Hertz sensation level guide. Gary likes that, I hope. I can give you a PDF for Sprint. You can look that up online too. I do have that. It didn't condense real pretty when I tried doing that. So that is what I have for you all today. This is my email, meganscottaud@gmail.com, if you need to reach out to me with any questions.
Thank you very much.
Thank you so much.
That was a lot of great information, Megan. Thank you so much.
You're welcome.
Everybody's coming over to my house for pizza tonight, so.
Well, that's not fair. I'm in Missouri.
Well, the flight arrives tonight at 6:30. Perfect. That's just when the pizza's arriving. Well, you guys, we're not done. Evidently, we take a break. I'm sure everybody's in favor of that.